Why why shoulder instability?
My shoulder instability. And probably why shoulders, I would say, because it's not just instability I treat, but certainly my research means around shoulder instability. Um, Part of that is probably just natural progression. So I worked in the national healthcare system for a period of time, and just kind of the way it happened within the department and opportunities, etc. I ended up working in a shoulder clinic with three fantastic shoulder consultants, and really learned a lot from them and started to then treat some of their complex cases. Um, and I was lucky within an department, they had a pretty good shoulder team set up already. So I had lots of people to learn from. All of those things, probably where I naturally kind of started to fall into that. Um, and then within that, you start getting, and mainly through the relationships with the consultants, they'll start introducing to the different societies, and you start networking that way. And then it
Yeah.
kind of evolves. And I think networking is probably a huge key. As I said, I was fortunate because my department had some excellent physiotherapists with shoulder specialists, with a shoulder interest as well. So yeah, I kind of developed from there, and then the network. And then that's where you probably start to develop your interest. Yeah, I was just really drawn to it. And not just shoulders, just generally as a whole, wanting to learn and try to learn from the best. Always try to surround myself with, people that I could really learn from.
Mm.
And then there's lots of those people within the NHS and within, when I came back to Ireland. So I was fortunate enough to be around some really good people to learn. And then I moved back to Ireland 10 years ago, and I got a position as the upper limb rehab lead for the sports surgery clinic in Ireland, which is a big private hospital. And from there, we deal with a lot of traumatic shoulder stability. So the surgeons would, there's about 400 shoulder saves in a year there, so a vast
Wow.
amount of shoulder instability. The expectations are very high for some of these athletes going back to play, and particularly some of your younger athletes. Like, how do we know they're ready? If they reoccur again, is this some to even to protect yourself, that you've done a good enough job here?
Yeah.
And is it testing the same as the other side? And for their own psychological confidence as well. We had very little out there. So that's where that kind of interest developed. And then within that role, it's not just the traumatic shoulder instability, I see complex instability too. So yeah, probably just natural progression, the way opportunities came up.
Yeah.
Um, and then, as I said, the networking part I think is really important. Don't be afraid to put yourself out there, go to conferences, have the conversations, link in with the people you want to link in with, surround yourself with good people. And the nice thing now, probably compared to maybe 15, 20 years ago, social media is fab. It's such a good way to connect with, I say fab, I got a bit of a love-hate relationship with it, but as a whole, being able to connect and then being able to access loads of stuff. There's so many podcasts now we can listen to.
Yeah.
There's so many online resources, isn't there? So that's really
Yeah.
nice. It's not, the world is much smaller now in a sense of being able to access the people you want to learn from.
Do you think
So,
that's with I'll give my opinion in a minute, but because of what you just said there, the podcast, the social media, etc., that clinical, if we call it knowledge updates, whatever you want to call it, that because they used to say it takes 7 years to get from research to practice, right? Because of now social media and because of podcast and other various means, do you think that's got quicker?
that's a good question. You would like to think so, wouldn't you, in a sense of like how many people actually sit down and read a research or know that a research paper has come out. I would have
Yeah.
never known anything other than I used to get the shoulder and elbow journal every month, and that was it. Or, the CSP one or whatever. And that's where you used to, or, through my masters, I would have had to read and that kind of thing. But other than that, I don't think I would have. Whereas
Yeah.
nowadays, it's at your fingertips. And it used to be Twitter. I like Twitter in the sense I could save all the articles that I wanted to read in. LinkedIn, I try and do the same. It's kind of a slightly different forum, isn't it? So, no, I think it's much, much easier to access the information now,
Yes. And
which
as a
is,
result, because well, again, I agree. Like, I think it's easier, and I feel like we can react quicker. So if there's updates, whatever it is, or changes,
mm,
it doesn't take maybe 7 years, maybe a year or months, depending on what it is and what the change is. Have you, and I notice it for especially for persistent pain and especially back pain. But have you noticed a change as more recently, whether it's instability related shoulder stuff or shoulder stuff in general, that because are you just seeing more of the complex, harder stuff that wasn't has had already had the what we'd consider decent rehab, decent advice, decent input that just isn't getting anywhere. Where in the past it may have been, well, why haven't they suggested this thing that's in the research? They just didn't know about it.
Yeah, as in, is the level of care gone up in a
Yeah,
sense
yeah,
of,
yeah,
yeah, yeah, I think as a whole, and I can probably only reflect on within Ireland and then, within teams that I'm often asked to go out into. Yeah, I think as a whole, the general, and particularly around things like, say, rotator cuff related pain, there's some really good evidence that conservative treatment is as effective as surgical management and,
yeah,
a graded and graduated program. And most people will, and part of that, eh, it's never just the exercises. It's how it's the education, but also the patient's belief system. Have you challenged that? Figured out the barriers to adherence. It's all a huge package, and I do think that just takes time as a
yeah,
therapist to build, and I'm still learning that. But as a whole, the exercise prescription, yeah, I would say so. And then even now, probably on the instability and particularly maybe on the athlete and return to sport,
mm,
there's a big push probably, around maybe objective markers and stuff. So we're probably a bit more answerable. Have we, addressed some of these markers before they've gone back to place? So we're probably a bit more answerable than time before, oh, it's 6 months now, you come back. And they could be
yeah.
6 months, but you know, 6 months means nothing.
No,
Are they
yeah,
ready to go back to play? So
yeah.
on those, yeah. So I think from that perspective, as a whole. But then the other tricky thing with social media is it's there's so much information out there. Hey, and not yeah, and it's trying to yeah, kind of delve into the useful information from that.
Yeah.
Um, yeah, particularly even as a clinician, but also as a patient.
I don't
Because it's
get a lot of these days I don't have to do much of the what I call normalizing the scan. Right, someone's had the scan, they're worried about the degenerative whatever. But we don't have by the time they come to us in a pain service where they've already hopefully had some physio input, some other input from whoever. That's normalizing bit's been done. So the days I refer to them as like the Peter O'Sullivan patients, the person who's like fed, scared of bending or twisting, worried about the change that's on the scan, tightening everything. In our pain service, we don't get a ton of that now because it's already thankfully been hopefully delivered or discussed
mhm,
um, ahead of time, way before us. Um, so I think the baseline is going up because we're able to access updates and research quicker. You don't have to wait for your weekend course once a year to then get the update. But sadly, that means you and I then get all the complex ones where it's still ongoing and there's multiple factors involved, etc. How are you
yeah,
how are
yeah,
you finding that jump now? Because you get a mix. You were telling me earlier of the athletes,
yeah.
and then you have the, as you say, complex second, third plus opinion, etc.
Mhm.
How are you finding the mix of one? I don't know, it's extreme to the other.
And I quite like the mix because we were kind of talking off air a little bit, and I was saying actually what's really helped me treat the athletic shoulder is able to treat some of the more complex, even from the mechanical perspective, I'll say complex instability.
Yeah,
Um, and a lot of the time with the shoulder, I feel like it's been able to bring them back down again to go up. Getting a safe entry level can be tricky on a really kind of whether you're trying to unlock range post surgery or whether it's just a really reactive shoulder. So getting a safe entry level in to then build confidence and progress from there. So that's where I always think some of those cases have been so complex. And if you get one exercise and you've got one way in, that's magic,
yeah,
and that can be tough in a very complex instability, one way that it's not coming out dislocating. If you can do one exercise, you got one way in, and then you can build up from there,
yeah,
challenging all the different roles of the rotator cuff and step down, all of those kind of things. So I feel like that helps me treat the athletes. So I generally, as a whole, I enjoy both. The athletes have, they're different. Obviously, they've time pressures and expectations are high, and they take a lot of programming. There's a lot to get through in a very small time frame, from rehab to kind of all these other elements of strength, power, psychological readiness. There's lots of stuff around there. And then you might have the complex one, whereas if you get one exercise and weigh in, that's often quite nice. And it's interesting there, you were talking about the lower back stuff. I certainly still probably have to challenge belief systems
Yeah.
even this week. Yeah, even this week. Probably this one was from a surgical, a consultant that had documented around things like impingement and attending impingement and not to lift above head. It's terrified to lift above head.
Really?
Mhm. And they can be very difficult conversations because, you always think you want to sing from the one hymn sheet, the one voice, but then when you have conflicting voices, they can be incredibly hard, and then even despite all the education, it's like, I don't want to conflict the consultant's opinion,
Yeah.
or the patient doesn't want conflicting,
Yeah.
and voicing that they don't want conflicting. So no, I absolutely still get the challenging and scans. And in Ireland, this is the other thing that's different to the NHS. So in Ireland, we have private healthcare. They all tend to have scans before they come to you.
Mm.
So a lot of shoulders are scanned. The MRI is often covered by insurance and not an X-ray. So they'll have tons of MRIs,
Oh.
and they might have come via the GP, and not necessarily, and gone different routes and stuff. So
Yeah.
there's certainly still a lot of tackling the poor correlation between what's on scan
Yeah.
and pain and all of those conversations. And if that's been reinforced previously by 3 or 4 health professionals, yeah, so no, and that might be a little bit within Ireland because of the access to the scans.
Yeah.
And then obviously we have excellent surgeons that are very much like, scans only used to plan surgery, that's all we use it for.
Yeah.
So
Yeah.
it depends, doesn't it? It's just still quite varied, and
That there's a
yeah,
greater risk of, uh, I say, iatrogenic effects or nocebo stuff early on. Is that right? Because they're going straight to the scan. I wish radiology had some nicer words to use for reports at times, but as you say,
yeah,
if you get told you've got torn
yeah,
whatever or degenerative whatever, then you're obviously going to panic about it. Because that's the first thing you're going to probably see. Do they get their reports before they have the conversation?
yeah,
Yeah.
yeah. They can access the reports themselves, so they
Yeah.
can go on an app and access it. Yeah, yeah, and whereas like
Mm.
impingement and yeah, tears, because every scan has a tear.
Mm. Of
You
course it
never, you never, you never pick up one without it, eh? So yeah, no. So I probably not all the time, but definitely there are cases where you are still, and they can be incredibly difficult depending on how that's being discussed to them, and depending who has discussed that with them, and you know, just yeah, the general hierarchy as such within the medical world, hey. So it's
Yeah. They're
yeah.
gonna most of the time, I'm not going to make a sweeping assumption, but most of the time, put more weight on the person with doctor in front of their name rather than not. Medical doctor, that is, to be clear. I realise you've got a
Mhm.
PhD. Um, how do you find challenging that? So you said about impingement there.
Mhm.
So someone's been told, I can't believe we're still using this term, but apparently it still is the
Mhm.
case.
Mhm. Yeah.
Whether it's that or whether it's about certain tear or something or whatever it is, and uh, you've now got this person in front of you, you've gone through your assessment, you've done it, let's say, we've now got this belief and the worry about the impingement. And I realise it could be varied depending what the scary term is.
Mhm.
But how have you found trying to manage those beliefs?
Yeah, I still find the challenging the beliefs of some of these, and particularly when you've had pain for a long period of time, one of the trickiest parts of the session or the with the patient. I think for me, where it comes, I'll spend a long time listening to them, so they know I've heard their story. I've moved very much, and I like. I feel like I can't help someone if I don't know the story because and I say it might be the belief system around the scam, but it isn't. There's normally 50 other million stuff going on in there.
Yeah.
So you're starting to build that picture. So I try as best as I can. There's some sessions I could sit and listen for 40 minutes. And I'm fortunate, and probably now I used to have an hour. Now I create even more time because most of the stuff I've seen is either complex or athletes come back and there's a lot of programming and I need the time. I can't do it effectively. So I have, within my working day, I create more time to be able to give that early on because it's nothing worse missing something early on that is likely going to reflect the outcome. So as best as I can for the first 30, 40 minutes, I'll have to just listen. And a lot of the stuff will come out from there. Sometimes it might be, hey, they don't want to, you're getting a feeling here, work is quite stressful. They might be off
Yeah.
work, but actually they're not too keen on that work environment. Or um, they've had previous surgery on the other side and they did physio for
Yeah.
3, 4 years. It didn't work. And now,
Yeah.
the brain has stored all of that. And now
Yeah.
they're like, and these are crucial parts to actually, you're going to have an impact here. How deep set is that belief system?
Yeah.
Or, their mother had it done and, they feel like they, have got a good income, all of those kind of things. There's so many variables, or they're not sleeping. There's a lot going on at home. There's all of those things. So yeah, I'll try as much as I can to get a good feel. And then when it starts coming down to all of this, I'll get an idea around sleep. I think that's a really nice way to see levels of without asking, are you stressed or you're anxious? It's like, well, what's your sleep like? And then they're like, yeah, I don't know. I've no stress at work or anything. And you're like, what's oh, I sleep for 3 hours. Oh, what's keeping you awake? Oh, and then you
Yeah.
suddenly, it's trying to build that therapeutic relationship with them
Yeah.
because if you haven't got that and then you come in on a confronting question, it can go very, very wrong.
Yeah.
Um, but also, if I don't understand where their head is or what their understanding is, it's very hard to then try and help as such. So I'll always say, what's your understanding of what's going on? And I'll right, so I'm right, you're saying this and this is because of this. Okay. Um, so, and then I might come, well, actually, what we know from, some of the, yeah, and I try not to go down the research route, but we know that actually people can have pain, even, and a lot of these findings you might have in your other shoulder, because that's actually, quite normal, some of those findings, but you still have pain. So trying to figure out what's driving that pain and yeah, breaking through that way. So I think a lot of that comes from the first 30, 40 minutes
Yeah.
that I've put to be able to do that because they're hard conversations to have and they will shut down on you if you, and then the session can feel very awkward and not
Yeah.
quite nice. And that's taken a while to do, and I still find some of those. Some are easier to work with. Some beliefs are so, so strong.
Mm.
And no matter what you do, or how you challenge, or how you phrase, or even if you bring somebody else in, um, some of them are very deep set, just like any belief we hold, because of
Yeah. Yep.
of all our previous
Yeah.
experiences.
Yeah.
And there's times that I've had to say, I'm not sure I can help you here, because, and I'm getting better at that and being okay with that sometimes because I think that's an important, depending on, and I'll be like, do you feel like we've missed something? Do you feel like you need a scan because you feel like we've missed something here? And
Yeah.
yeah,
Yeah. I tell people all the time it has to be the right time for someone. And fundamentally, we can't change everyone's beliefs. Like there are
no.
some people of course, majority of people, they'll be in somewhere in the middle where they're open to suggestions. And if we've built enough, as you say, rapport, trust, um, and they're open to idea, then of course it's easy, it's changeable. But for a very few people, this isn't everyone, but as you rightly say, and I completely agree, there's a few people who, for whatever reasons, and it's not just one thing, as you say, it's multiple things that have occurred over time that have come together, and that belief is set. Uh, and no matter how much, as you rightly say, research or stories or whatever
Hmm.
we use or experience or behavioral challenge, all that stuff, it's just not going to go there.
Hmm.
It's just not going to shift for whatever reason. And maybe they've become part of their identity in a way. It's become part of so ingrained into life. Um, Interestingly, we find the ones that are more, if we call it structurally focused rather than open to biopsychosocial, are classically your kind of engineers,
Oh, okay.
that kind of for the jobs where you change something and there's an effect, like
Hmm.
like you change the torsion of something and then there's an effect afterwards, and it's um, also, and some people talk about people from the army.
Or
Um,
the techie sometimes, hey, as well.
yeah, where it's
Yeah.
just everything is input output, and it's related to
Yeah.
the thing you do. It's not the effect of everything else going on in life doesn't have an impact. Um, as you say, sometimes you just have to, if it's not
It's
the
how
right
the
time,
brain,
it's
yeah, and how
yeah,
that your own experience have wired all of those connections,
yeah,
isn't it? And it's because they are the other thing here. They are hard conversations to have. They are quite, I don't know about you, but I certainly find them, it's hard to be confrontational. It probably doesn't come naturally to me. So but and I'm not confrontational in a way of any aggression. It's more like, oh God, what's your understanding of that? But then like it takes energy, it takes time. It's much easier to just go and give them a few exercises.
yeah,
Much
yeah,
easier.
yeah,
When I get that, I'm like, great. But if you have 3 or 4 of those in a row, it is exhausting,
yeah,
and everybody wants to go there because of the what it brings up, the impacts. You're more likely, you may fracture your therapeutic relationship here because
yeah,
they may not be open to it. It comes with a little bit of it's definitely, it comes with a bit of it, and how you are as a person as well. I've got some colleagues, one colleague that's amazing at confronting, and he did it was very different to how I did it. So this is a difficulty. I'm not sure you can teach all of this in university.
no,
I think part of it comes with time, because also the other challenge is how you manage that information as a person. Try not to, put the boundaries of them, doesn't ruminate with you and stay, all of those kind of things, that we protect our own selves as well. And we're,
yeah. Now, but actually, stay on that topic. So we said about sleep, stress, etc. I'm thinking of someone who's got quite significant instability. What I found particularly difficult is that you're having the conversation, you're going through it with them, and you want to try and introduce these elements. And they may come across at some point, they may come up and say, yeah, well, my shoulder's still popping. How is my stress and my sleep and work and all these other stuff? How is
mm,
that affecting my shoulder actually just popping in and out all the time? Uh, and what pains we've got more, how can I say, data research stories, what everyone is behind.
mm,
But this is obviously a bit more niche.
mm.
How do you, is there a way you've found to help it link the two together?
Yeah, I think with instability, it's probably got a few different spectrums, in a sense of it can be very mechanical. Hey, so you have
Yeah.
your traumatic instability, which is, they've dislocated, done bony damage. That's one entity as such. Then you can have this atraumatic instability, and it could be more that they are naturally hypermobile, hyperlax, had an event, and then had numerous events, and it's quite a muscular thing. So they have, a biomechanical thing, and they actually often respond really, really well to exercise. I don't often have to go down, although it might have a psychological impact and fear of reoccurrence, because it's never nice when it happens, or they don't have confidence in it. But actually, that there's certainly a cohort that respond very well to exercise, and then you can have this other cohort of um the kind of functional neurological disorder,
Yeah.
almost, of really complex instability, and some horrendous cases, and how they present, and often it can be sometimes in a very young cohort. So they could be, 11, 12,
All right.
come in with a very dysfunctional,
Mm.
swimming or gymnastics at an event, and then it transforms and you know that it almost looks like neurological, so you're having to clear all this other stuff. And then it just finds there's a lot of stuff going on from what's happened with it at school or horrendous stuff
Yeah.
to like what's going on in the home environment. And these are extremely difficult because you have the parents. There might be an issue with the relationship with the parents.
Yeah.
And then you might see some, you know, what they're doing harm to themselves, like they can get, and how it's presented in a, just like shoulder's definitely an area where it can present in, and then
Mm.
something else might start to look, you know.
Yeah.
So they're incredibly difficult. I'm not sure it's yeah, whether you go down more so the pain science of that because it's a functional thing, it's instability, it's coming out of joint that can't
Yeah.
function. Um yeah, and then and the reasoning behind that, and it gets, as I said, often it is in that young population. Get it within you have certainly have 20-year-olds, 25-year-olds as well, but certainly a number of young people where the parents are there as well, and then being able to, part of that is I think with kids, so with adults sometimes obviously you can listen, they can hear you, kids don't always.
No.
With a kid, you got to get a way in. Like, what do they enjoy doing? What music are they into? You got to get a therapeutic. You'll have some that give you absolutely nothing.
Yeah.
Yeah, and sometimes I used to ask a couple of young lads, and I'd get some of the strength and conditioning coaches in, even though this is complex instability, I'd be like, or functional neurological disorder. I'm just, they're connecting with these better than they are with me, and being able to bring them in, and they suddenly get something out of them, and I'm like, okay, and it's, yeah, it takes a while because you got to develop a relationship. And then, as I said, often the parents are there as well, and that can sometimes be a help and sometimes a barrier.
Yeah.
And some of those are really, really tough cases.
Mm.
It's
Very
a
tough.
huge impact, and
Yes.
it's escalating. Yeah, yeah. So they
And then you're
tricky.
having
So I'm
to,
not. Yeah, sorry.
I was going to say, then you're having to manage the parent and the kid.
Yeah, yeah, because it's parents' understanding that's going to affect this as well as the kids' understanding. And
Yeah.
I would say it's the parents' understanding more and being able to, and then, sometimes if you want to try and have a chat with one and the other, and this can come and I've seen it in athletes that have had surgery, and surgery hasn't quite gone the right way for them, still have a lot of pain afterwards. And then you can tell they're not happy. Hey? And it's still this, the shoulders aren't letting me go back to play. And that was
Yeah.
my thing. Yeah. And part of that is just having that relationship with the patient and being able to have that connection and that therapeutic connection. And um, I think definitely being flexible is in, if you're not getting that, don't be afraid to bring in someone that you think is someone that's, for me, sometimes some of the younger guys that are a bit more, what's going on. So they make the connection for me and they help me, so that has helped me in the past. Um, yeah, being able to rely on others and not just your experts, but anyone across the department.
Yeah.
Yeah.
Yeah. There's times where our uh, therapeutic assistant, if we call it that, or assistant has um, built more rapport and trust and got help someone more than any of the clinicians of
Mhm.
various expertise and various specialities, because whatever it is, it's about the her and how she is or her mannerisms, or just because she's in a different stage of life to some potentially other people they've seen, or because she doesn't have doctor in front of her name.
Yeah,
I don't know, but sometimes because it's just someone, it might not even be anything to do with your, how knowledgeable you are, or how
for sure. Yeah.
good your whatever plan is. It might just be the fact that you either look a certain way, or a certain, maybe you remind them of someone they got, who knows, everyone's got their
Hmm.
unconscious biases.
Hmm.
um I don't know what we can do about that, because it's not like we can always ask people in advance, do you know what your unconscious biases are?
No. But it's being aware of that, isn't it? And
Yeah.
not being
Yeah.
afraid to because it's all about the patient, isn't it? Trying to get them the best outcome.
Yeah.
And just because you're qualified so long or whatever, that means nothing. That doesn't mean you're going to help everybody.
No.
There's so many elements. It's not just the exercises, or the amount of instabilities you've seen. I've seen thousands and thousands and thousands. It doesn't mean that I can help everyone, and it doesn't, yeah. And particularly in some of those functional
Well, yeah.
neurological disorders, the muscle patterings, yeah, they can be really, really, really tricky. So I don't know if the shoulders, from that perspective of instability, is it always the pain science part of it? Because, as you said, they're coming mechanically out of joint, and it's not that they're always sore. Either, instability isn't always painful. It might be very
Mm,
functional, as in they can't function. Um, they don't like keep their arm on one position, or it'll come out, or
yeah.
yeah.
I presume the same applies to strength as well. Like some people may take the assumption that, oh, if we just get you strong enough, it will stay in, right?
That's the easier assumption, isn't it, as a
Yeah.
clinician, because it doesn't take it doesn't take as much out of you to prescribe, I think anyway, to prescribe. And it,
No.
certainly for instability, it is. And do you know what I have done before? I have spent time where I've sat down with them, heard the whole story, challenged their belief system, gone into the whole pain science stuff. It's like an hour in, and then I'm like, geez, I better have a quick look here. Have a quick look. And they have the most dysfunctional shoulder mechanically. Like, scapula's gone one way, the shoulder's gone the other way. And I've changed it really nicely with exercise. And I'm like, oh my God, I've just spent like the whole entire hour doing that. And the most dysfunctional shoulder and neck. So I've now started to, like, depending on how I'll always listen and then maybe look and then come back to those
Yes.
conversations,
Yes.
because I've absolutely done that before. And you hear all of these things, and sometimes, and that may be a shoulder perspective, maybe more than the back, perhaps. So I definitely think there is an element around control and strength.
Yeah.
And from the athletic perspective, you see a lot of those, say you're working on control, strength, and power, like that obviously affects performance. Then, like, I think it massively. So, a big thing with athletes who've had a dislocation is the fear of reoccurrence.
Mm. Oh,
Um, confidence in the shoulder, confidence to perform again, confidence in the rehab, confidence in surgery, all of those kind of things. But the fear of dislocation is huge,
yeah.
and even probably it looks like more so than within the ACL. So it's a big component there. And in fact, we've done some research looking at we're about to publish, looking at the seriously score, which is like your psychological readiness to return to sport. And a lot of these athletes go back around 4 months, and that's where the score drops compared pre-surgery. When they are going
Mm.
back, that fear is really high, because it's not a nice feeling coming out. It's not a nice feeling to wait 3 hours to get that in A&E. And particularly after having a surgery, the fear of having to go through rehab again, hey, for another 4 to 6 months, the fear of being out of a game. So it's a
Yeah.
huge element. So, and I think that's where the objective markers and the feed nicely into the psychological aspect, because you can be saying, hey, you're as good as the other side here.
Mm.
And these numbers are what we would expect for someone who hasn't had a shoulder injury. You've worked really hard here. And then you're putting a lot of graded exposure back in with contact work. VR is probably in vogue at the moment. Virtual reality that you
Is
might
it?
take them through. Mm-hmm.
Mhm.
And not just for this cohort of return to sport, is in, like, you're putting them through tasks in immersive reality before you put them into play, but also in the complex shoulder,
Mm.
fear of movement, those functional disorder, some of those things as
Yeah.
well, and giving them the confidence, because they're like, there's some medical apps where they pick apples from the tree and put them into a bucket, and
Oh.
they put them into immersive VR. So these are people that haven't moved the shoulder for a long period of time. Put them into immersive VR, and you record them, and they're doing this, and they're like, "Is that me doing it?" So there's some really, Beata's a physio in Europe that's doing a lot of work on it, and you've Brady here in Ireland. There's some, they're working with Jeremy Lewis on some really cool stuff
All
on
right.
VR. So I think, it's another tool. Hey, the athletes like it because
Are these goggles that they put over? Like what is
yeah,
it?
like your ocular quest, like
Oculus.
your
Ah,
yeah.
fine.
And then there's more coming out where like you've got special gloves on, so you can then. So this is what I've been learning apparently. Is these special gloves on, and then they can feel, say, contact with the ball.
Oh,
So you can actually go through some of that recurrent to contact because for the athletes it's the first bang. They need to get through the first ball and the first bang. I don't
yeah,
think they ever, when you speak to them or you're talking to them, they never. It's getting through those, no matter what you say, because you're like, this is awesome. Hey, this is even better than the other side, and but it's still getting through those kind of first contact elements, and even when we talk about, is it just all about strength? In this population, the qualitative research will show that, like for younger athletes, the ability to produce force is really important. And for patients' range of motion is important, whereas shoulders or surgeons would put stability higher. So it's funny how all the
yeah,
stakeholders have
yeah,
different things that they feel are important. But the patient, yeah, of course, is important for those athletes. That's what the qualitative research shows. It's been able to produce forces. They rate it over stability.
it sounds like the easiest way. Well, it's not that it's going to change overnight, obviously, but for the fear is essentially them being gradually exposed to more and more, and they experience like it's basically a long-term behavioral experiment,
Mm-hmm.
right? And they're having more and more input,
Mm-hmm.
and they gradually fall, and you do all the. Yeah, I guess this wouldn't just apply to athletes; this would apply to anyone,
Yeah, for
right?
sure. Yeah,
Um,
yeah, yeah. Like any phobia or any fear, isn't it? And actually, Margie was a physio at New Zealand. I've been linking her with Kai closely because she deals with a similar population to me, but she's doing work on that graded exposure. So she puts photos of somebody dislocating, an athlete dislocating on their phone.
mm,
And then so that's there on their phone, and then it changes to a more severe one and a more severe one over time. So yeah, some of that graded exposure of,
yeah.
and actually some of them really can't look at the photo.
Yes, that would make sense.
Yeah,
If you're
yeah.
really
So it
afraid,
is
yeah,
yeah, and it can be really traumatic injuries about a sport, potentially career affecting. So it is certainly yeah, lots of things going on within that cohort as well. Yeah.
what about if I flip the other way? So not an athlete, but let's say, 30-year-old Dan who works in IT and goes to the gym a couple of times a week, and he's happened to have been playing football with his mates, fallen, popped it, first time,
Mhm.
A&E, X-ray, nothing broken, pop it back in, off he goes. And he's about, I don't know, let's call it a month down the line. He's sat in front of a clinician, doesn't have to be physio space, could be GP, this could be anyone. There's no scan at this point, but he's not dislocated again. And he asks us, will this happen again? We don't have a scan to say if he does or doesn't have any labral or other major injuries, but
Mhm.
what should we say to kind of try and help him give him confidence at this point?
Yeah. And you know what? There's lots of emerge and lots of research now out around the copers and the non-copers, essentially, say
Okay.
post first time dislocation. So we know factors, and Margie actually has a really nice scale. Like what's it, the predictive reoccurrent instability scale. So you can actually score it a little bit because some factors will make you higher
Ah,
risk. So age
okay.
is a huge variable here. The younger you are, the higher the risk of coming out. So at
Ah,
30, your risk is so low. So much, no, not so low. It's much lower than,
is it?
say, significantly lower than an 18-year-old, 19-year-old,
Mm,
20-year-old, 14, 15, 16-year risk is incredibly high. So age is a huge factor here. Sport, if he's not playing contact sport, if you play contact sport, your risk is higher. Um, if it's the dominant arm versus the non-dominant arm. There is some stuff around structural damage, so that's where you obviously need some scans or whatever. But someone like him, as a first port of call, you're 30, you're not playing if he's not contact sport, he's in the gym, hey, so he's going to have to still probably want to get back to a previous
yeah.
level within there. So there's lots of factors in his favor. So yeah, you can actually score it, PRSI scale. You can score it, and
All
that'll
right.
help give you confidence and them confidence about where you fit in there.
Mm,
As I said, there's couple of questions around the because if you've had bony damage, particularly what you call a bony Bankart, where some of the glenoid
Yeah.
has been fractured, your risk is higher. So some of
Okay.
that's around the structural stuff as well. And then they have some other scales like your kinesthesia, phobia. Yeah, so but straight away I'm hearing 30 and it's not very conscious. There's a very chance he'll do
Really?
really well with but also I would say with structured rehab here, I'd still be, if he wants to go to the gym and be able to floor press or bench or do whatever, you're gonna have to get a pretty stable shoulder there. So
Yeah.
it's not good enough, I don't think, just giving him rehab exercises, because that's not going to equate to what he's going to do in the gym. So I definitely think there's a matter of, that progressive getting control, building up into strength, into being able to work under load, inflection, abduction, and those other planes. So it does take a bit of
Yeah.
planning and work to get there. And when that kind of someone that isn't an athlete and doesn't have tons of time to prioritize it all the time, so you might get him rehabbing say 2 to 3 times a week.
Yeah.
That'll take a good 3 or 4 months to get that really good, and a
Yeah.
lot of structure and putting together. And you do, like, for me, I don't need to see these a lot because it takes 3 or 4 weeks before they're good enough to go again.
Mm.
There's no manual therapy. You can do some PNF techniques. Not in my opinion, that's going to massively speed that up, but it is getting a safe entry level in, and then getting him controlled. In these positions, probably where he's most vulnerable, knowing how to get him up here and not
Yeah.
avoiding that, because you got to be able to learn how to control up there. So there's lots of tricks and ways into to yeah. So I still think it is we do them a disservice if we don't give them a comprehensive program. And I would say for someone, hey, we've a good chance here based off these scores, and your age is on your side here to really and depending what he wants to get back to as well. But
Yeah.
yeah, on a whole, that someone like that, you'd be fairly confident if you do a good job that we can, they would be on the lower risk of.
Low risk.
And then it's a shared decision making
Yeah.
process, isn't it? Like if
Yeah.
they desperately want surgery, I'm like, okay, go have it. That's okay too.
Yeah.
Um,
Speak to a surgeon, exactly.
yeah, yeah. So it's definitely a shared decision making. Although I have my biases, I really try and lay out all the options here
Yeah.
because something does happen. They'll be like, tell me this, and then that's where we have to do. It is a and they ultimately have the final
So,
say in that, don't they?
yeah. Do they that score, first of all, what was it called?
The PRSI, what's it? The predicted reoccurrent instability scale. Predictive reoccurrent instability scale.
I will link
Yeah.
that below so people can
Yeah,
grab it.
too. So Margilles has done some really nice research on that. And
And
yeah,
is the
so
recurrent is
yeah,
the
for
recurrent because as we get older, our collagen gets tighter or stiffer? Is that
yeah,
right?
I think so. I think we're just generally not as as we are when we're younger. So your risk is, and you'd rarely, like, if you see a shoulder dislocation at say 40, the likelihood is they've done the dislocation, and the reoccurrence rate is so low after that age. It's more likely that they've done a cuff tear or something.
Oh, okay.
It flips a little bit. Now, on the flip side, the really hard cohort to manage is like your 14, 15, 16, 17-year-old,
Mm.
because um they're like, it's a huge, age is a huge factor here. So if they have an event, even if they have surgery, say they have an arthroscopic Bankart repair, they're 16, and they
Mm.
have surgery and they go back to contact sport, what do you think the survival rate is at 4 years?
So they're 16.
Yeah,
They've had
they've
a
had
Bankart repair.
15, 16, they've had a Bankart repair, they go back to their contact sport.
How long have you given it to return? 6 months, let's say.
Uh, yeah, yeah. Often with the young ones, you'll hold on longer because the risk is higher.
Let's say. Okay. I will make a guesstimate of, so their likelihood of relocating, let's go with, judging off what you're saying, 40%?
95% reoccurrence rate.
Whoa,
Yeah, 5%.
95. Which
So
begs the
these are
question, why are we,
why are we doing it in the beginning?
yeah, yeah.
Yeah, yeah. And the now this is based off Len Funk's a big surgeon in the UK, so he does a lot of athletes. So they put a paper out, I think it was Emma Torrance, if you whenever we look at it, but it's their survival rate at 4 years. And our surgeons will often say, similar, you'll have them at 16, they'll be coming again and being operated at 18. It's because, and partly like they can't do the more like the Latarjets or some of those because of, so the Latarjet is a coracoid transverse, this non-anatomical bony kind of reinforcement as such. Their reoccurrence are much lower than an arthroscopic Bankart repair, but in a young athlete, and particularly in males, the glenoid bone formation lags behind. So, that'd be often not appropriate within that age. Now, occasionally you'll see it done, and they'll sometimes do a remplissage, which is another type of procedure if they have a big defect in the bone to kind of yeah, but the rate's incredibly high now. It'll be high whether
Yeah.
they have surgery or not. So and those are the conversations because you're like, what difficult conversations? They can be difficult conversations.
Yeah.
And I know one of our surgeons will say, like, he'll say, the parents, and these are hard for the surgeons too, because they're, what's the chance of it reoccurring? And he's like, well, it's the chance of the other one reoccurring because shoulder dislocations are very high in that population in young contact athletes, whether you, no matter what, you know what I mean?
Yeah.
So there's an element of that as well, because it's
Yeah.
in that age, much more so as as you get into your 20s. So they're very tricky.
Oh, wow.
Mm.
That is a
Yeah,
hard one. Yeah. We're going to
yeah,
surgery repair, but
yeah.
you're likely going to relocate again afterwards. Ooh.
And it's the parents more so because some of these on trajectories, these can be coming up to international teams. They've been playing rugby since they were 6. They're in the schoolboy rugby clubs. All of these things. It's so embedded within families and hopes pinned, and they're the like when you're starting to have 2 surgeries under the age of 18 on a shoulder, like you know
Do we know
they're
if
big time, their time's out, and all of those kind of elements and confidence in the shoulder and
do we know if it has long-term effects? We may not have the data yet, but down the
uh,
line for
on performance, I don't think,
on
or more on like the joint
arthritis, stuff
itself.
like that. Yeah, yeah, yeah.
Yeah, we know the more dislocations you have. So if you're a first time dislocator versus if you've had 10 dislocations, you're going to
Yeah.
be, most studies will show you're more prone to some arthrogenic changes and those things down the line,
Okay. Okay.
and it is a question often asked about the latter days because, they're obviously that non-anatomical block, and they're much more over the last, say, 10, 15 years. Being done a lot more because of the demands of the sport as well. And I
Yeah.
know when you hear the surgeons speak about them, they'll say they're done since the 1950s, and it doesn't show that. I'm not sure they've been done these kind of, because they've been done in France for a long time in these kind of numbers. But certainly the more dislocations you have, so you don't want someone, even if you've treated them conservatively and they're coming out again, that's probably when you go into, and you've tried to optimize everything, that's when
Yeah.
you would, because you don't want someone having 5, 6, 7, 8 dislocations on a cubaceous capsule, because you're gonna end up just, doing bone protrusions and all of those kind of things.
Yeah. How do we help a mid-teen or later, someone, fairly, may even be going for university still, help them understand what a labral tear is? Because you can use all your bank arts and slaps and whatever,
Yeah.
that will mean nothing to them. Uh, how have you found the best way to try and explain it to them at that age?
Yeah, that's a good question. I draw a lot,
Okay.
so I will, and sometimes I just get blank faces. The parents are really interested, but the kid, no. They just want to know what they're doing. They just want to get back to playing. That's all
Yeah.
they're bothered about. They're not going to think shoulder health. They're thinking kind of, I'm going to be there for that championship game. Am I going to be there for, and I would say that really through a lot of even within your 20s, shoulder health is absolutely, their life is the sport.
Mm,
It's a social circle. That's all they want to get back to. So I'm not sure how much some of those as you say, want that conversation. They
yeah.
just want to know when they are ready to go back to play.
Mm,
That's probably their most important thing. But yeah, also I'll draw it out. You can use the kind of, the the suction on a washing machine type thing, if that comes off. But the washing machine functions really well if we get all the other parts still functioning very well for you. Um, a radiologist actually this week we were at doing some education, and he did a baby bell and had like the cheese around it.
Oh, okay.
It was amazing. And he had all the like cut out the little bit of cheese as the Hill-Sachs lesion and then showed how it engaged. And so that was really, really creative. So yeah, generally I'll draw.
Okay.
And then I'll gauge it. I'll gauge the room. I'll gauge the patient, how much they want to know as to how much I give. But generally, the parents absolutely want to know everything. They want to know the
Do
risk. They
they?
want to know.
It's their
Yeah,
child.
because yeah, exactly. That I'd say they probably, you know yourself about children. You'd be
Yeah.
more worried about them than you are. If it
Yeah.
was your own child, you probably wouldn't care. But when it's your child, you're like, and the really hard thing there is because you're like, well, should I have surgery or should I have not? You know, it's still quite a grey line for certain cases, and you're trying to, because you can't make that decision. You're trying to give them all the information there to help them make the correct choice, or help them make the best choice for themselves. So yeah, there can be a lot of time on the education, but certainly the parents off to.
And
Yeah,
if we went
I'd
the other
say.
way with age, so someone in their 40s or even 50s per se, and they happen to have a fallen dislocated, and let's say they happen to have had a scan and that shows some form of labral injury, I presume the question about invasive management becomes a lot more about risk and is it worth it? Is that right?
You'd rarely see it. I can't remember the last time I've seen a 40-year-old have uh, particularly a traumatic one, because generally, as I said, that they're much stiffer. So they might have done some structural stuff. It'll
Yeah.
go back in, but the risk is lower anyways. Just making sure they haven't done a cuff tear. If they
Mm.
haven't done a cuff tear, they generally do quite well conservatively. And the other thing is these can stiffen up. So if you do a repair on them or even a labral repair, they can end up with a very stiff shoulder, and they stiffen up much
Mm.
more than say your young shoulder that'll dislocate. They can get full range within a week or two sometimes. Whereas these other
Really?
ones, yeah, it's the 40-year-old, 50 takes forever to get the range back. They get incredibly stiff. So
Mm.
it's a very different presentation. Yeah. So it's stiffness, and they're bothered about function and range and pain. They can sometimes be more painful.
Yeah.
Pain and stiffness in that, I would say, but definitely the stiffness in that shoulder. So, and really, surgeons don't like operating on stiff shoulders, because the
Mm.
likelihood is if you operate on a stiff shoulder, it's going to be worse post-operatively, because you're going to have to immobilize it for 4 weeks,
Yeah.
and then probably an absolute nightmare to get the range back. There's nothing worse, on a stiff shoulder, because once you start knocking out that range, you knock out your function. Yeah, so they become a whole other problem.
Talk to me about this problem. And how do you manage these expectations long term? You've got
But
someone's gone in with their stiff shoulder, they've had the surgery,
yeah, and they're end up stiff
and they're
afterwards.
stiff afterwards.
Yeah, well, you do your best if you have any control over it. The surgeons will often ring you and ask that, they want them seen pre-operatively. So
Okay.
some of our surgeons wouldn't operate on them until they, and I would like to think that's a good chunk of them wouldn't operate until they have a pretty decent range, because they know the post-operative journey, the likelihood is they're not going to be happy with the outcome. Um, so yeah, your big key, and a lot of that, it's a protective measurement though. Hey, like for me, a lot of that is cuff stiffness. It attaches into a good 35% of the cuff attaches into the capital, so it'll
Yeah.
shut down as a protective measurement, and it's getting ways in to unlock that function again. And so a lot of that, like instabilities, like to be prone. They're like an anterior block on the shoulder, versus you're not going to get anywhere lying on your back here where it feels quite unstable. But if you flip them over, put a block, I hang out on the bench all the time. I have their arms supported with it, and your big job is get away in to unlock that safely. And then there's lots of different close chain, lots of you know, tricks and ways in to do that.
it's as you say, as earlier, finding that way that they can do the thing that helps them feel a bit more confident that you can then build on over time. It doesn't
Exactly.
always have to be a
And
perfect formal exercise, does it? It must be
no, no.
some.
And expectations. Let them know that. Hey, these take a
Mm,
while. This is
mm,
very expectations is so important from your athletes to any of them. Because particularly around shoulder instability, because it is setting those expectations and you know, under promise and over deliver is my
yeah,
advice because there is nothing worse, particularly with an athlete that feels like they're behind.
yeah,
And so many things affect that in terms of not all shoulder staves are the same. You'll get some that are very happy and you can hit your markers very quickly, and some that are quite slow and really shut down. And some of that's got to do with type of surgery, the amount of structural damage,
yeah,
how much was done in there. Some of these contact shoulders, front and the back of the labrums come off. I've had some that I've had 10 anchors in there. That's a very different shoulder to your normal, like 3 to 7 o'clock of 4 anchors. But then their teammate was back at 14 weeks, so their expectations is the same, but they've had bicep stenotomy on that. And, so having those conversations, so you have an idea of what the surgeon's going to do pre-surgery will give you a good idea of what the outcome is post-surgery. So the surgical element, but also the quality of the shoulder beforehand, the age of the patient, um, lots of different things can affect it. And although you might think 4 weeks, 6 weeks isn't a long time, it's a long time in an
yeah,
athlete. That
yeah,
can feel like forever.
yeah,
Particularly when the buddy was back in 14 weeks or 15 weeks, and then it's 20 weeks and they're not there.
yeah,
That can be huge for them. Yeah. So if you can set the scene and give the scenarios beforehand, it'll, I think, make your post-operative journey, because there is nothing worse picking them up on the expectations are totally skewed. And for me, because it's all I see, I've probably seen about 2,000 states. I've done on athletes in the last 10 years. So you get
yeah,
quite, I don't know if it's a good bad thing, you get quite familiar with pattern recognition. But in day one, as soon as I pick them up, I know if it's a happy shoulder or a non-happy
yeah.
shoulder. And that's, but as well, there's complications with latter days. Yeah.
Have you had to have any, how can I call this, career conversations with after an injury like this about if they're
Um,
going to be able to?
yeah. Yeah. And probably, on some of the higher level athletes is I might be in there as the shoulder opinion and the shoulder physio, but they'll often have their own physios as well that they work with or within their teams and stuff. So on those kind of where the career is their career, as in
Mm,
the sport is their career, it would never just be me probably having
no,
those conversations, because there's a lot of nuanced stuff going on in the background there. And the more their physios or their own physios and docs know them better than anyone. They'll know what the career is like, how they've coped with other injuries, if they're in mid-contract, where there's so much stuff going on in the background. So yeah, there's certainly a couple of cases that stand out where they've had shoulder surgery and they're, say, 34, 35, and they were expected, and the media's expected them to come back within 14, 15 weeks. But actually, sometimes these types of surgeries on an older shoulder, particularly some of the labral stuff, because
mm,
my feeling on this is sometimes it's like a degenerative labral as well as maybe some traumatic stuff. But
yeah,
you then put anchors in there and it can really, really, really shut down. Um, yeah, in that 35 or 34-year-old that's still competing at a really high level, whether it's MMA or some of those sports as well. And when you pick it up and you're like, oh, it's incredibly painful, incredibly shut down.
yeah,
There isn't a chance in hell they're going to be back in the time.
yeah.
And then, yeah, they're hard as well, because then they're often going looking for other opinions as well, so you can get, yeah.
Do you think they know? They ever get the sixth sense that they know in advance this may be
Uh,
it?
None. The one I have in my mind certainly didn't, and
Really?
actually this wasn't done for anything major traumatic. He had some pain in the gym and ended up having this done on some labral stuff and a biceps tenotomy. And I'm sure he wouldn't have had the surgery if he thought that was going to be. So, the surgical decision making is so important, as
Mm.
in not just the findings on the scan, but that correlates with the mechanism of injury, because you see all of these contact athletes have labral changes. Of course it is,
Yeah.
or MMA, or, and there's a very big difference between, say, a degenerative labral and an acute trauma, and labral repairs them for instability. In my experience, anyway, it's different for, doing something to the labrum that is an instability, for pain or something. I'm not sure.
Adele, before we get into your hardest conversation, was there anything about shoulder instability that you wanted to say in the conversations around them that I've missed?
No, I think we've
No.
covered lots there.
We have covered quite a lot. Tell me about your
Yeah.
hardest. I ask everyone your
Your
hardest, one of your hardest
hardest.
clinical conversations.
Oh gosh. I'm trying to think now. Like, as I said, a lot of those tend to be around challenging the belief system,
Mm.
and probably there's lots. Even this week, I had an incredibly difficult one around the belief system, and even after, I didn't get a way in because she was, or this patient in particular, was told something, and
Yeah.
by previous health professionals, and it was the fear of contradicting a surgeon's opinion around, which, so there itself, and as I said, it's, you always ruminate about those. Could you have done those better? Or, they can be, I always find those incredibly difficult. And some of the, yeah, I certainly remember a case of a functional neurological disorder, and, in a young kid, and the parent was always present, and the way they were moving, they almost looked like they had scoliosis, because the scalpel had gone one way to try and lift. The muscle patterning was so severe. So
Yeah.
went down the route. I mean, you have to clear that it isn't scoliosis, had a neurologist, had a pediatrician, all of these things. And because the poor parents are just trying to find out the answer of what's gone on
Yeah.
here, and you could get some change within session. So I knew it wasn't, but you still have to clear all of these. But then trying to have the conversation with the parent, probably more so, that, hey, the likelihood is here there's something else going on. And then that transpired that it was parents going through a tough time and
Uh,
having the impact on and this was interesting. They'd gone away for then it transpired there was a lot going on within the club, the sports club as well, that they were in. And then the child had gone away and for 3 weeks on holidays with the parents, and they got to connect with one of them. They're playing water volleyball, and there's a shoulder that didn't move for 9 months. Came
yeah.
back fully functional after being away for 3 weeks in connection with it. And there was others, it was difficult because you could see harm marks and other stuff. So they can be, yeah, trying to get to the bottom of those, and you feel responsible because they're often, you're trying to coordinate all these other appointments, as rightly or wrongly, as a physiotherapist, because it's probably, you've seen this before. It's more within
Yeah.
your realm versus the GP, and
Yeah.
trying to suggest and getting a child psychologist. Yeah, and as I said, it was another difficult case again, with it probably with a parent, and this was in a college student that's had two shoulder surgeries but hasn't been able to go back to rugby since the shoulder surgeries, persistent anterior shoulder pain following shoulder stay. No matter what exercise you did, like, this wasn't just, I couldn't get away in. And I can know if it's mechanical, I can normally get away in,
Mm.
or, could not get away in at all. And the eye connection wasn't there. You could tell he was so depressed, and
Yeah.
then
Mm.
and you're trying to have those conversations of, like, you're not going to be able to have this person until they understand what's driving this, and understand actually the child is probably going through something here. And
Mm.
to have those conversations have to be very delicate, because they're then like, if you're suggesting anything mental health or psychology,
Yeah.
or that can really backfire and
Yeah,
on
yeah.
the child themselves at like 19, 20, or not the child, the adult at that stage, So those, yeah, that was incredibly difficult. And you're trying to communicate that to, and in a sense, sometimes I'll have to try and grab the parent by themselves and be like, and I approach it sometimes, but maybe let's, because he's obviously really affected in the D's out of sports. Maybe a sports psychologist here as a way in, that I don't lose them
Mm,
completely.
yeah.
Whereas they're still fixated, and this particular chap is very fixated on the fact of it being he's in persistent pain. The surgeries didn't do anything. He's had two surgeries now, and he's still bilateral shoulder pain. He's still not playing. That was a really, yeah. They're probably sometimes when you have, yeah, there's lots of difficult conversations. I
There is.
probably feel like I have them every week. There's so many, and there's certainly ones I ruminate and stick with me, and I've had to really try hard to get better at putting barriers up that it doesn't, you know, yeah, because you have to protect your own mental health and not burn
Yeah,
out yourself. Hey,
yeah,
because I think as physios, all we want to do is help, and we can't help everyone. And then if something goes wrong, we blame ourselves, those kind of things. Or so, yeah,
yeah.
that is a whole.
I heard someone once say it's a coat you put on when you go to work and you try to take off when you go home.
Yeah,
So you don't carry it home. It's not always possible because things happen
yeah,
inevitably. I know uh, my wife would be not good at what we do because she takes lots of, she describes herself as an empath. So she takes on a lot of these
yeah,
emotions. So she would
yeah,
struggle. Uh, but I think we also have to accept that it does happen because if you just try to ignore it and just try to, no, I'm not going to take anything home, it's like the pink elephant in the room, isn't it?
yeah,
You
yeah.
can't.
And some of the cases are so
Mm.
sad, and so yeah, and or you might have a kid the same age, and all of those impacts, and you're relating to it from that aspect, and you see the pain they're going through, and that's just humans, isn't it? That's probably, I feel like that's probably those because I'm probably quite empathetic as a whole, like that would it's a superpower as well.
Yeah,
You
yeah,
have to protect yourself, eh? It's a
yes,
bit of both. It
yes.
certainly helps you in your career within our job, I think, because you care. I
Mm,
think that's the main thing. Patients just want to know you care. And that's where your colleagues come in, isn't it? That you
yeah,
have time. But unfortunately, like in some of the environments we were working in, it's just so easy. You don't even get time to talk to your colleagues. Although you can have 70 working in a team, it can still feel very lonely because you need
mm,
to get home, so you don't have the time to talk. But being able to, because your colleagues will have been through it as well, and that helps, doesn't it?
yeah,
Shared
yeah.
experiences, and yeah, being able to have, use each other as much as
Well, our psychology colleagues, well, they'll have their, what's it called, supervision, where they will sit and
yeah,
talk to someone every, whether it's a week or two or month or whatever it is. Uh, and I know we have other many professions have it like your supervision for tricky cases where you're trying to work out what's
yeah,
going wrong. But it's not as much of a thing where we, have the
debrief.
supervision debrief, exactly.
Mm,
Um, but as you say, that talking to someone about it, it doesn't have to be someone even who's got as much experience as you. It could be someone who's not as much.
absolutely, yeah,
Even just talking to someone about it um, can help. I agree. Maybe well, I see it happening a bit more where this supervision for just debriefing and how you're getting on is occurring
mm,
more across other specialities beyond psychology. Maybe a time well long before it becomes for everyone, but we'll
yeah.
see. We'll see.
And what I find is we're really good at doing it for our junior colleagues and supporting our junior colleagues, but
Mm,
then the top we don't give ourselves that. I don't know if the word's the top layer, but the more experienced
yeah,
layer,
yeah,
because you're generally the source that people come to.
yeah.
I'd be in a cubicle, I could have 3 or 4 people waiting to talk to me. I'm in the middle of like this super complex case. I'm like, Jesus, my head is gripped here. I can't,
Yeah.
and I find some, and I had an excellent colleague. He was our head physiotherapist, but he was amazing, and even being able to have those or weigh in or being able to bring him in for some of those, it just took the pressure off me because
Mm,
sometimes you feel like but someone else. picking you up, and yeah, and being as you said, being able to debrief. But I sometimes feel the more experienced you are, the less opportunities you have to debrief because everyone's debriefing to you rather than the other way.
Yeah.
I don't know if you find that as well, but
So we thankfully in a pain service, it's become a bit more routine.
it's
And I've still
clear.
got someone above me who I can debrief to.
Yeah.
So it's a bit. I think it's become accepted because we have psychologists in our team, so it's more accepted. It's more expected as well.
You go to
But
the psychologist often to see your patient, and you feel like that sometimes, don't you?
yeah, and that's okay.
That's okay.
That's, and I think I always tell people, you have to, especially in pain, you have to be become a little bit emotionally immune. I think for me, that's more genetic,
Yeah.
just how I'm wired. And for some people, like my wife, for example, she'd be opposite. She would really struggle with that. She'd take everything in. Um, and we're obviously, people go into a healthcare role because they're hopefully caring and kind people. But then it's being careful not to take on everything.
Mhm.
Um, and as you say, as you get experience, there's a risk that people just assume that you're tough now and you can take it
Yeah.
in. And that's not always the
And
case.
then sometimes it's circumstantial, like it's the patient you mightn't think would affect you, but it does because it's circumstantial because someone close to you is gone. It's all of those.
Yes,
We're humans as
yes,
well, aren't we? But
yes.
yeah, it is. I do think it would be nice to see more of that. Yeah, and it's yeah, and they're the things you don't learn in university.
No, no, because you can't. Yeah, that's more
Probably.
of an
No, you
experience
can't.
thing.
I agree. I agree. Yeah.
We can,
But
we
having
can,
conversations and knowing we're all going through it,
yeah,
it's part and parcel a little
yes.
bit.
Before we finish, Adele, I'll ask everyone at the
Yeah.
end, what's the future? So in your case with shoulder instability,
Hmm.
what is the future of shoulder? You was mentioning about VR
Uh,
there earlier.
yeah. I think preventative in the
Okay.
young athletes, probably. More so things like, say, in the young contact athlete, it being rather than being grouped by biological age, but your maturation age. So you're not potentially playing with someone that is significantly more physical than you. All of those kind of things will help reduce injury risk because I do think that's a big thing in the younger. If we
Mm,
can prevent it to some degree, and some of that comes, I think we can probably get them better equipped in the gym. Some of the resistance strength is a lot of push and pull and heavy work, and they're not working in some of these more dynamic positions. Part of me thinks you need gymnastic shoulders to play some of these sports, particularly in Ireland, like hurling, football. They go in lots of different directions. So I think we can do a better job there in education. With the parents and the things like the tackle techniques, all of those are really important. So I think there's a huge space for some involvement around shoulder instability in sport and contact sport on the um, the preventative side in the early years, and
yeah.
then as we go along, probably a lot of talk around, your first time dislocator, you know, a lot of those go for surgery, how many need to, trying to get a little bit more of a grasp on the copers and non-copers, I suppose, of that. And then, yeah, around fear of all of that psychological readiness is quite in vogue at the moment, and how to address and tackle all of those. They are like the big key thing here is that you'd like ideally some really controlled, randomized control trials showing really comprehensive rehab risk. I don't know if we'll ever get to that stage that they're ever able to control all of those elements. But yeah, definitely around education, the a big thing around the biological maturation age. And you can have and in Ireland anyway, you'll have like under 16s in with under 18, say in rugby, they'll
Oh,
could be called up to the Irish team and they're 16,
all right.
up to 18. And if you have a December birthday, you think these are small, these are huge things. So if they're grouped by yeah, and that's where they have the dislocations because the player is significantly bigger than them.
Mm,
So the resistance training will really tend to take off 15, 16, 17, 18, those, that kind of proportion. So they seem like fairly easy, low hanging fruit that can hopefully, so I think New Zealand do it. Actually, we have some of our county hurling teams doing that now, which is really nice to see. And some really great people like Angela Jackson. She's putting out fabulous stuff in the UK on it. There's apps now that will record it. I think all of that will help because the last, like if that's a risk factor, if you've had one, you're more likely to happen again. So
Yeah.
yeah,
Yeah.
that's probably my thoughts on where, and I think the testing will evolve as well. Um, and yeah, there's not just the objective stuff, but the cognitive stuff while the decision making. Oh, yeah. So yeah, no, lots of interesting
All right.
areas always.
Good.
Yeah.
Good.
Yeah.
And well, Adele, if people want to find out more, they can find you on LinkedIn, right, and contact you that way.
Yeah.
The we can say you said there's a physio tutors course about to come out.
Yes, on the mastering performance in the sporting shoulder. Yeah, so that is due out shortly. Which has been really nice putting kind of the years of work into trying to program all that together and the programming from the control to the performance side. So yeah, that's exciting. That should be out shortly.
Ooh. That's online, I presume. Is that right?
Yeah,
Yeah.
online. Yeah, yeah.
Okay. Anything you wanted to say that we've missed?
No, no, thank you so much for having me on. And as I was excited about this one because I've heard some of your other podcasts, and I think sometimes because we often talk about all this mechanical stuff, but it's such a small part. It is the
Yes.
communications, building the
Yes.
relationships, but that's also the fun part. Like as I said, as much as like I say, oh, it can be tough. I actually really love hearing people's stories. Love
Mm.
hearing, yeah, I find it fascinating as well.